Welcome to Chapter 10 of the BCSC Glaucoma series. In this chapter, we'll focus on secondary angle closure, an important but often complex area of glaucoma. Unlike primary angle closure, where the mechanism is typically pupillary block in anatomically predisposed eyes, secondary angle closure arises from a wide range of underlying conditions, each with its own distinct cause and clinical presentation. As we move through this lecture, we'll build on the foundation we've already laid in earlier chapters, and now shift our attention to understanding how other ocular or systemic processes can lead to angle closure. This will help us recognize the key mechanisms, identify distinguishing features, and review management strategies for each type. Here is a quick snapshot of what we'll be going over today. Secondary angle closure can arise in many different settings, such as neovascularization of the anterior segment, inflammation, or after surgery. It can be divided into cases with pupillary block and those without pupillary block. We'll also cover how to detect these conditions at the slit-lamp, often with the help of gonioscopy. For neovascular glaucoma, we'll see how control improves with anti-VEGF therapy, especially when combined with panretinal photocoagulation, which often avoids the need for surgery. And finally, we'll review the importance of asking about medications in patients who present with acute bilateral angle closure, particularly drugs like topiramate, which are well known to cause this problem. Secondary angle closure can be classified into two main categories, those that occur with pupillary block and those that occur without pupillary block. When pupillary block is not the cause, we think about two possible mechanisms. The first is a pushing mechanism, where the iris is physically displaced forward from behind. The second is a pulling mechanism, where the iris is drawn forward into contact with the trabecular meshwork, usually because of membranes or fibrovascular tissue. It's important to remember that these mechanisms are not always mutually exclusive. In some patients, both pushing and pulling forces can be present at the same time, working together to produce angle closure. Here is a table outlining the underlying mechanisms of non-pupillary block angle closure. As we discussed earlier, these can be grouped into anterior pulling mechanisms and posterior pushing mechanisms. We won't go through each item on the list right now, but instead, we'll take the time to break these down in detail on the following slides so you can better understand how each mechanism contributes to angle closure in different clinical scenarios. Secondary angle closure can be divided into two broad categories, those with pupillary block and those without. Under pupillary block, the most common subtypes include phacomorphic glaucoma, ectopia lentis, microspherophakia, and aphakic or pseudophakic angle closure. On the other side, without pupillary block, we think in terms of mechanisms, pulling, pushing, or a combined mechanism. This framework helps us organize the many different causes of secondary angle closure into a systematic approach, making it easier to recognize the underlying etiology in clinical practice. Let's go through each of these causes. Phacomorphic glaucoma is multifactorial, but the most important factor is the mass effect of the cataractous lens. Pupillary block often contributes, and angle narrowing typically develops slowly as the cataract progresses. However, in some cases, it can present acutely. This occurs when the lens becomes swollen or intumescent, which can trigger pupillary block even in eyes that are not otherwise anatomically predisposed to closure. Let's talk about diagnosis of phacomorphic angle closure. Distinguishing phacomorphic from the primary angle closure spectrum is not always essential, since the treatment approaches are generally similar. However, there are a few key differences worth highlighting. These include the anterior chamber depth, the appearance on gonioscopy, and the overall degree of cataract present. Anterior segment imaging is especially helpful in these cases. Techniques such as anterior segment OCT, ultrasound biomicroscopy, and Scheimpflug imaging provide objective measurements. On OCT, eyes with phacomorphic angle closure show an anterior chamber depth of about 1.4 millimeters, which is roughly half that of controls, and a lens vault that is 3 times higher than normal, about 1.4 millimeters compared with 0.4 millimeters in controls. These features together reinforce the diagnosis and help us understand the anatomic crowding that drives angle closure in phacomorphic eyes. When it comes to treatment of phacomorphic angle closure, the traditional approach has been to perform a laser peripheral iridotomy followed by cataract extraction once the eye is quiet. However, in many cases, the iridotomy itself is not actually necessary. Cataract surgery alone can be both definitive and vision restoring. It's important to note that cholinergic agents have no role in management here. They can actually worsen pupillary block, shift the lens-iris interface forward in cases of zonula laxity, and make cataract surgery more technically challenging by constricting the pupil. The OCT images on the right illustrate these dynamics, showing how the angle can remain narrow even after an iridotomy, image A, and how light-induced constriction can deepen the angle transiently, image B. Image C shows improved angle depth by laser iridoplasty. Next, let's discuss ectopia lentis, which is defined as displacement of the crystalline lens from its normal anatomic position. When the lens moves forward, it can lead to pupillary block, iris bombé, narrowing of the angle, and ultimately secondary angle closure. This forward shift is what makes lens subluxation an important mechanism to recognize in angle closure disease. There are many possible causes of lens subluxation. The most common is pseudoexfoliation syndrome, but we also see it in cases of trauma, Marfan syndrome, homocystinuria, and in less common conditions such as microspherophakia, Weil-Marchesani syndrome, Ehlers-Danlos, and even rare enzymatic deficiencies like sulfite oxidase deficiency. The clinical images on the right illustrate how striking the lens displacement can be, ranging from subtle subluxation to complete dislocation into the anterior chamber. The treatment of choice for ectopia lentis is to create 2 laser iridotomies, placed 180 degrees apart. This approach helps prevent the lens from occluding both iridotomies at the same time, relieves the pupillary block, and serves as a temporary measure until the lens can be definitively extracted. Ultimately, lens extraction is usually required. Removing the lens restores vision, reduces the risk of recurrent pupillary block, and prevents the development of peripheral anterior synechiae. In this way, lens surgery not only treats the acute problem, but also protects against long-term damage to the angle. Microspherophakia is a congenital condition where the lens takes on a spherical or globular shape rather than its usual contour. This abnormal shape can cause significant complications. Most commonly, the lens may slip out of position, a finding known as ectopia lentis. In addition, the rounded lens can create a pupillary block, which may progress to secondary angle closure. When it comes to treatment, cycloplegia is helpful because it tightens the zonules, flattens the lens, and pulls it posteriorly. This action relieves the block and prevents further complications. In contrast, miotics are contraindicated. They actually worsen the problem by loosening the zonules, pushing the ciliary body forward, and making the lens even more globular, which can intensify the pupillary block. Microspherophakia is often familial. It may appear on its own, but it is also associated with systemic conditions such as Weil-Marchesani syndrome and Marfan syndrome. On the right, you can see an example of ectopia lentis caused by microspherophakia. The lens is trapped against the pupil, creating iris bombé and a dramatic shallowing of the anterior chamber. In aphakic or pseudophakic eyes, a pupillary block can develop when the vitreous, a dislocated lens, or even an intraocular lens obstructs the pupil or the iridotomy site. This leads to impaired aqueous flow and results in a characteristic iris bombée with a shallow anterior chamber. For medical management, the initial approach includes mydriatics and cycloplegics, which help restore aqueous flow. However, these agents may make an iridotomy more challenging if the lens remains fixed. Topical beta blockers, alpha-2 agonists, carbonic anhydrase inhibitors, and hyperosmotic agents can be used to lower intraocular pressure before proceeding with laser treatment. Laser iridotomy is often necessary, and in many cases, more than one opening may be required to bypass the obstruction. There are several special considerations. With anterior chamber intraocular lenses, the iris bows around the implant, creating a shallow periphery and a deep central chamber. In these patients, multiple early iridotomies or even an iridectomy are often required to prevent pupillary block. Despite these measures, complications can occur, including persistent block if the lens haptic or vitreous obstructs the iridotomy. Another scenario is pupillary block after posterior capsulotomy, especially if the vitreous herniates forward and obstructs the pupil. Additionally, capsular block syndrome can occur when retained viscoelastic or fluid pushes a posterior chamber lens forward, narrowing the angle and creating a block. We've already touched on the fact that not all secondary angle closures are due to a pupillary block. To reinforce this point, remember that secondary angle closure can also occur without a block, through either a pulling or a pushing mechanism. Pulling results from contraction of membranes in the angle that form peripheral anterior synechiae, while pushing involves forward displacement of the lens-iris interface, often from ciliary body swelling. The first pulling mechanism we'll discuss is neovascular glaucoma. This condition produces severe secondary angle closure driven by abnormal blood vessel growth in the anterior segment. These new vessels form fibrovascular membranes that spread across the iris, the pupillary margin, and the trabecular meshwork. As these membranes contract, they physically pull the angle closed. The main underlying cause is ocular or retinal ischemia. Common culprits include diabetic retinopathy, central or branch retinal vein occlusion, and ocular ischemic syndrome. Each of these conditions creates the ischemic drive that stimulates neovascularization. Other associations to keep in mind are intraocular tumors such as retinoblastoma, medulloepithelioma, or choroidal melanoma, as well as prior radiation treatment, which can also trigger this aggressive form of glaucoma. Neovascular glaucoma develops as a result of potent angiogenic signals, especially vascular endothelial growth factor released from an ischemic retina. These new vessels can form not only in the setting of clear ischemia, but also in conditions like Fuchs' uveitis, pseudoexfoliation, or even iris melanomas. If no obvious ocular cause is identified, always consider the possibility of carotid artery occlusive disease driving the ischemia. Clinically, patients present with an acute rise in intraocular pressure, decreased vision, significant ocular pain, conjunctival hyperemia, and often microcystic corneal edema. The neovascularization pattern is fairly characteristic. It typically begins as fine tufts of vessels at the pupillary margin, then extends radially over the iris, and eventually crosses the angle with fine branching vessels at the ciliary body and scleral spur. The trabecular meshwork often takes on a reddish appearance. Complications occur when the fibrovascular membranes contract, producing peripheral anterior synechia, progressive angle closure, and ectropion uvea. A key distinction from other causes of secondary angle closure, such as ice syndrome, is that in neovascular glaucoma, the synechia begin right at Schwalbe's line. On exam, a bright slit-lamp beam with high magnification is essential to pick up these early fine vessels before they progress to irreversible closure. This image highlights the classic appearance of iris neovascularization. As we've discussed, the process typically begins at the pupillary margin as fine, delicate tufts of vessels. Here, you can see a more advanced stage with radial extension of those abnormal vessels spreading across the iris surface. This vascular network eventually invades the angle, where contraction of the fibrovascular membrane leads to secondary angle closure. This image shows a more advanced stage of neovascular glaucoma. As the fibrovascular membranes extend into the angle, their contraction pulls the iris root forward, creating peripheral anterior synechia. These adhesions progressively close the angle, locking in elevated intraocular pressure and leading to secondary neovascular glaucoma. This image demonstrates end-stage neovascular glaucoma. At this point, the angle is completely closed by broad peripheral anterior synechiae, and the iris neovascularization that initiated the process is now obscured. The key feature to notice is that these synechiae end right at Schwalbe's line. The fibrovascular membrane cannot extend beyond this point because it does not grow over healthy corneal endothelium. This image demonstrates how iris neovascularization begins at the pupillary margin and then progresses radially toward the anterior chamber angle. You can see the abnormal vessels extending across the iris surface, making their way into the angle structures. The prognosis for neovascular glaucoma is typically poor, which is why prevention and early diagnosis are critical. Careful gonioscopy is especially important since angle neovascularization may be present even in the absence of iris vessels, such as in a small subset of central retinal vein occlusions. The definitive treatment is PRP for ischemic retinopathy. By reducing the ischemic drive, PRP remains the most effective way to decrease new vessel formation and slow disease progression. Adjunctive therapy with intravitreal anti-VEGF can provide acute regression of neovascularization, sometimes even normalizing intraocular pressure. This effect is often enhanced when combined with PRP. The major benefit of anti-VEGF is that it improves the success of later glaucoma surgery by lowering angiogenic drive and reducing intraoperative hemorrhage risk. In the short term, topical medications such as beta blockers, alpha-2 agonists, carbonic anhydrase inhibitors, cycloplegics, and even corticosteroids may help reduce intraocular pressure or inflammation, but these are temporizing measures. For surgical management, tube shunt surgery with valve devices is the preferred approach in many cases, especially once regression has been achieved with PRP or anti-VEGF. If visual potential is poor, CPC, either endoscopic or transscleral, can be considered as a palliative option. The next pulling mechanism we'll cover is iridocorneal endothelial syndrome, or ICE. This is a group of disorders characterized by abnormal corneal endothelial cells. Instead of behaving like normal endothelium, these cells act more like epithelial cells. They proliferate, migrate across surfaces, and lose their normal contact inhibition. This cellular abnormality leads to three key consequences: variable iris atrophy, secondary angle closure, and corneal edema. Clinically, ICE presents in three distinct variants. Chandler syndrome is the most common, making up about half of all cases. The essential or progressive iris atrophy variant is defined by marked iris changes and hole formation. And finally, Cogan-Reese syndrome, also known as iris-Neva syndrome, is characterized by pigmented nodules on the iris surface. Clinically, ICE syndrome is almost always unilateral and occurs more commonly in women, usually presenting between the ages of 20 and 50. The exact cause is uncertain, though a viral association has been suggested, as lymphocytes are sometimes found on the corneal endothelium. Typical findings include elevated intraocular pressure from chronic secondary angle closure glaucoma, decreased vision from corneal edema, and variable iris changes. On slit-lamp, the corneal endothelium often shows a characteristic beaten bronze appearance, similar to what is seen in Fuchs dystrophy. There are several special features to keep in mind. Microcystic corneal edema can appear even when intraocular pressure is not significantly elevated, especially in Chandler syndrome. The fellow, unaffected eye may sometimes reveal subtle endothelial irregularities on specular or confocal microscopy. High peripheral anterior synechia are common, and importantly, they extend anterior to Schwabe's line. Finally, the degree of angle closure does not always match the intraocular pressure, because the endothelial membrane itself may cover the angle without necessarily forming synechia. This image shows the classic high peripheral anterior synechia seen in iridocorneal endothelial syndrome. Notice how the adhesions extend anterior to Schwabe's line, which is a hallmark feature of ICE. In this particular case, the patient also has essential iris atrophy, adding to the distorted anatomy. This finding highlights one of the key distinctions between ICE and neovascular glaucoma. In ICE, the abnormal endothelial membrane grows directly over the angle structures, creating high anterior synechia. In contrast, in neovascular glaucoma, the contraction of fibrovascular membranes typically anchor synechia right at Schwabe's line. As we briefly touched on before, ICE syndrome comes in 3 clinical variants. Essential iris atrophy is straightforward. It's marked by severe, progressive iris atrophy. Patients may show heterochromia, chorictopia, ectropia on uvea, stromal thinning, or iris holes. Chandler syndrome is different. Here, iris atrophy is minimal, but corneal changes dominate. The hallmark is corneal edema, which you can remember as a chalky cornea in Chandler. That CH link helps recall that Chandler is all about the cornea. Cogan-Reese syndrome, also known as iris-nevus syndrome, has less severe atrophy, but it's defined by pigmented nodules or diffuse lesions on the iris surface. You can remember this as Cogan collects color, colored nodules or freckles on the iris. This photograph demonstrates the classic findings of essential iris atrophy, the most severe variant of ICE syndrome. You can clearly see chorictopia, where the pupil is displaced from its normal central position, as well as iris holes resulting from progressive stromal and epithelial atrophy. These structural changes give the iris an irregular and distorted appearance, and over time, they contribute to angle closure through the pulling mechanism we've been discussing. This image shows Chandler syndrome, the ICE variant where corneal changes are the most prominent. You can see ectropy and uvea in this case, but what defines Chandler is that iris atrophy is minimal, while corneal edema is the main feature. About half of all patients with ICE syndrome will go on to develop glaucoma. The risk is highest, and the disease tends to be most severe in the essential iris atrophy and Cogan-Reese variants. The mechanism comes down to abnormal endothelial behavior. The corneal endothelium migrates posteriorly onto the trabecular meshwork and iris. Unlike normal endothelium, these cells vary in thickness, may form single or multiple layers, and are surrounded by collagen and fibrillar tissue. They also contain filopodia and actin filaments, which give them motility. The outcome of this cellular migration and contraction is the formation of peripheral anterior synechia. These adhesions progressively close the angle, ultimately leading to chronic secondary glaucoma. When diagnosing ICE syndrome, it should always be considered in a young to middle-aged patient who presents with unilateral secondary angle closure. One of the challenges is that ice can sometimes mimic primary open-angle glaucoma, especially if the iris and corneal changes are subtle. That's why a high level of suspicion is important in the right clinical setting. Specular microscopy is especially useful. It typically shows asymmetric endothelial cell loss between the two eyes and reveals atypical endothelial morphology in the affected eye. These changes confirm the abnormal endothelial behavior that drives the disease. Management of eye syndrome is directed both at corneal changes and elevated intraocular pressure. Corneal edema can be treated with hypertonic saline, while pressure is managed with aqueous suppressants or prostaglandin analogs. Medical therapy has limitations. Miotics are generally ineffective, and while medications may temporarily reduce pressure, they rarely provide long-term control. Surgery is often required. Trabeculectomy or tube shunt surgery are the main options when medications fail. Trabeculectomy carries the risk of late failure due to endothelialization of the fistula, but YAG laser can sometimes reopen a closed tract. Tube shunts are often favored for more durable control. One important point: laser trabeculoplasty is not effective in ice syndrome. The abnormal endothelial membrane covering the trabecular meshwork prevents meaningful response. Another rare pulling mechanism that can lead to severe secondary glaucoma is epithelial and fibrous ingrowth. These are uncommon surgical complications, but when they occur, they can be devastating. The mechanism involves epithelial cells, fibroblasts, or both, migrating into the anterior chamber through a wound site defect. Once inside, these cells proliferate and contract, pulling the angle closed. Fortunately, the incidence has been reduced significantly with better surgical and wound closure techniques. Still, certain risk factors increase the likelihood of ingrowth, such as prolonged inflammation, wound dehiscence or delayed closure, tears in Descemet's membrane, and even complications following procedures like DSEK. Between the two, fibrous ingrowth is more common than epithelial ingrowth. Epithelial ingrowth is diagnosed clinically by the presence of a grayish, sheet-like membrane that may extend over the trabecular meshwork, iris, ciliary body, or cornea. It is often associated with wound-related complications, such as vitreous incarceration or wound gape, and may also present with ocular inflammation, hypotony from choroidal effusions, and corneal edema. On histology, the membrane is composed of non-keratinized stratified squamous epithelium with a thin subepithelial connective tissue layer. A green laser can also be used to help confirm the diagnosis because it produces characteristic white burns on the epithelial membrane. If the diagnosis remains uncertain, cytologic examination of an aqueous aspirate can be performed. These images demonstrate epithelial ingrowth, one of the rare but serious surgical complications that can lead to secondary glaucoma. On the left, you can see diffuse corneal haze and opacification, reflecting the sheet-like epithelial membrane that has spread across the anterior surface. On the right, gonioscopic examination shows a grayish membrane extending into the anterior chamber angle. As mentioned on the last slide, the underlying causes often include vitreous incarceration in a wound, wound gape, ocular inflammation, or hypotony from choroidal effusions. Once established, these epithelial sheets can contract, pulling the iris and angle structures into abnormal configurations and leading to progressive angle closure. Treatment of epithelial ingrowth is challenging, and unfortunately, the prognosis is generally poor once the process is established. One option is cryotherapy, which can be used to destroy epithelial tissue within the eye. More aggressive cases may require radical surgery, which involves removing the intraocular epithelial membrane along with any affected tissue, followed by fistula repair. Whether or not to intervene depends on several factors: the extent of the disease, the patient's visual potential, the status of the fellow eye, and their overall circumstances. In some cases, conservative management may be chosen if the risks of intervention outweigh the potential benefits. Fibrous ingrowth is caused by fibrous vascular tissue proliferating into the eye after a penetrating wound. Compared to epithelial ingrowth, it usually progresses more slowly and, in some cases, may even be self-limited. Clinically, it appears as a thick, gray-white vascular retrocorneal membrane with an irregular border. This vascularized tissue can extend into the angle, leading to peripheral anterior synechia formation and destruction of the trabecular meshwork. In some cases, ectropion uvea may also develop as a complication. Although less aggressive than epithelial ingrowth, fibrous ingrowth can still cause significant secondary glaucoma when it contracts and pulls on the angle structures. Trauma can also lead to secondary angle closure, and importantly, this occurs without pupillary block. The underlying mechanism is the formation of PAS after injury to the eye. There are several potential causes. Angle recession following blunt trauma can disrupt the normal anatomy of the angle. Direct contusion injuries may lead to structural damage. Hyphema can set the stage for inflammatory and fibrotic changes. And inflammation itself, whether acute or chronic, can drive synechial closure over time. The unifying feature here is that trauma initiates structural or inflammatory changes that result in progressive angle closure independent of pupillary block. Now we move on to pushing mechanisms, beginning with tumors and cysts. These conditions can cause unilateral secondary angle closure. Common causes include choroidal melanomas, ocular metastases, and retinoblastoma. Anterior uveal cysts may also play a role. The mechanism of closure is twofold. First, as the tumor enlarges, it physically shifts the lens-iris interface forward, narrowing the angle. Second, breakdown of the blood-aqueous barrier can lead to inflammation, posterior and peripheral anterior synechia. As a complication, tumors can also induce anterior segment neovascularization, further contributing to angle closure, which ties back to the pulling mechanism we discussed earlier. Next, we will talk about malignant glaucoma, also called aqueous misdirection or ciliary block glaucoma, which is a rare and severe form of glaucoma. It most often follows ocular surgery in patients with prior angle closure, though it can occasionally occur spontaneously in predisposed eyes. Clinically, the presentation is distinct. There is uniform flattening of both the central and peripheral anterior chamber, unlike the iris Bombay configuration seen in acute primary angle closure. Importantly, you may notice asymmetry between the affected and the fellow eye. As for mechanism, the older explanation was anterior rotation of the ciliary body with posterior misdirection of aqueous, leading to a block at the lens equator, vitreous face, and ciliary processes. Today, it is recognized as multifactorial, involving small predisposed eyes, choroidal expansion, and reduced vitreous fluid conductivity. This complex interplay is what makes malignant glaucoma particularly challenging to manage. This ultrasound biomicroscopy image highlights the anatomical changes seen in malignant glaucoma. You can see that the entire lens iris diaphragm is pushed forward, leading to a uniform shallowing of the anterior chamber. The central portion of the anterior lens capsule is nearly in contact with the cornea, which explains the dramatic chamber flattening seen clinically. Notice also the ciliary body detachment, a finding commonly associated with malignant glaucoma. Together, these structural changes reinforce the mechanism of aqueous misdirection and the unique clinical presentation of this rare but severe condition. Again, malignant glaucoma presents with a shallow or flat anterior chamber and anterior displacement of the lens, intraocular lens, or vitreous face. Occasionally, optically clear zones may be seen in the vitreous, though this remains controversial. It is often difficult to distinguish from choroidal effusion, pupillary block, or suprachoroidal hemorrhage. Helpful diagnostic clues include the IOP level, the timing after surgery, confirmation of a patent iridotomy, and whether effusion or hemorrhage is present. In uncertain cases, surgery may be necessary to establish the diagnosis. Management of malignant glaucoma begins with aggressive medical therapy. First-line treatment includes intensive use of cycloplegics, aqueous suppressants such as beta blockers, alpha-2 agonists, and carbonic anhydrase inhibitors, as well as hyperosmotic agents to help dehydrate the vitreous. It is critical to avoid miotics as they tend to worsen the condition. Laser therapy can also be attempted. YAG laser may be used to disrupt the anterior vitreous in aphakic or pseudophakic eyes, while ciliary body photocoagulation can be applied to alter aqueous dynamics. Outcomes vary. About half of cases can be controlled with a combination of laser iridotomy and medical therapy. The remaining patients generally require surgical intervention. The definitive surgical approach is pars plana vitrectomy combined with hyaloidozoneulectomy, iridectomy, and anterior chamber deepening to restore normal aqueous flow. Next, we will talk about uveal and ciliary body effusions, which occur when fluid or blood accumulates in the potential space between the uvea, specifically the choroid and ciliary body, and the sclera. There are a variety of causes. These include medication-induced reactions, such as sulfonamides, complications after panretinal photocoagulation, as well as inflammation, infection, trauma, and prior surgery. Retinal vein occlusion, tumors, and uveal effusion syndrome are also important contributors. The underlying mechanism involves a supraciliary or suprachoroidal mass effect that pushes the lens iris diaphragm forward, resulting in angle closure. In addition, exudative retinal detachments may act like space-occupying lesions that shift the retina and intraocular structures forward. Examples include retinoblastoma, Coates disease, metastatic carcinoma, and choroidal melanoma. Other causes include suprachoroidal hemorrhage, choroidal effusion or detachment, ocular infections such as HIV, and subretinal neovascularization in age-related macular degeneration when associated with extensive effusion or hemorrhage. Sclerobuckles, particularly when an encircling band is used for retinal detachment repair, can sometimes result in secondary angle closure. This happens because the buckle may lead to shallowing of the anterior chamber angle, or, in severe cases, complete angle closure. This effect is often accompanied by choroidal effusion and anterior rotation of the ciliary body. The peripheral iris becomes flattened, while the central anterior chamber may still appear relatively deep. The proposed mechanism involves compression of the vortex veins, which increases venous pressure and contributes to effusion formation. Clinically, the anterior chamber may gradually deepen over days to weeks with medical therapy. This includes the use of cycloplegics, anti-inflammatory agents, aqueous suppressants such as beta blockers and carbonic anhydrase inhibitors, and hyperosmotic agents. If medical therapy fails, additional interventions may be necessary, such as laser iridoplasty, drainage of suprachoroidal fluid, or even adjustment of the sclerobuckle itself. It's important to note that the buckle can obstruct venous outflow, which raises episclerovenous pressure and intraocular pressure. In such cases, improvement may only occur if the buckle is loosened or repositioned. Finally, iridectomy is not beneficial in this condition since the mechanism is not related to pupillary block. Parr's plan of vitrectomy can also result in secondary angle closure. This typically occurs due to intraocular tamponade agents such as air, long-acting gases like sulfur hexafluoride, perfluoropropane, or perfluoroethane, and silicone oil. Because these agents are less dense than water, they rise to the top of the eye and may obstruct the iridotomy site. To reduce this risk, an inferior iridotomy can be performed, allowing aqueous to bypass the obstruction. When intraocular pressure rises after vitreoretinal surgery, management strategies depend on the underlying cause. If silicone oil is responsible, it may need to be removed. Similarly, expansile gases should be evacuated once their tamponade effect is no longer required. If an encircling element contributes to the angle closure, it can be released. In more resistant cases, standard glaucoma surgeries such as trabeculectomy, tube shunt implantation, or cyclodestructive procedures may be necessary. Parr's plan of vitrectomy can also result in secondary angle closure. This typically occurs due to intraocular tamponade agents such as air, long-acting gases like sulfur hexafluoride, perfluoropropane, or perfluoroethane, and silicone oil. Because these agents are less dense than water, they rise to the top of the eye and may obstruct the iridotomy site. To reduce this risk, an inferior iridotomy can be performed, allowing aqueous to bypass the obstruction. When intraocular pressure rises after vitreoretinal surgery, management strategies depend on the underlying cause. If silicone oil is responsible, it may need to be removed. Similarly, expansile gases should be evacuated once their tamponade effect is no longer required. If an encircling element contributes to the angle closure, it can be released. In more resistant cases, standard glaucoma surgeries such as trabeculectomy, tube shunt implantation, or cyclodestructive procedures may be necessary. Nanophthalmos is a condition where the eye is normal in overall shape but abnormally small. The axial length is less than 20 millimeters, the cornea is small in diameter, and the lens is relatively large for the eye's size. Because of this anatomy, these patients are typically markedly hyperopic and at high risk for angle closure, often at a younger age than primary angle closure patients. The thickened sclera can also impair vortex vein drainage, predisposing them to choroidal effusion and even serous retinal detachment. Clinically, the greatest concern is that choroidal effusions may occur spontaneously and trigger angle closure. Intraocular surgery carries very high risk and is often complicated by these effusions. Management begins with non-surgical measures such as laser iridotomy, peripheral iridoplasty, and medical therapy for intraocular pressure control. Intraocular surgery should be avoided if possible. But if surgery is absolutely required, prophylactic posterior sclerotomies may be performed to reduce effusion risk, and lens extraction is often considered to prevent angle closure in the long term. Prophylactic measures, including decompression with a Honin balloon or systemic hyperosmotics like mannitol, can also help reduce intraoperative complications. Persistent fetal vasculature, or PFV, is a developmental anomaly where remnants of the fetal vasculature persist and lead to secondary complications. The key mechanism is contraction of retrolental fibrovascular tissue. This contraction progressively shallows the anterior chamber angle and can eventually cause angle closure. Swelling of a cataractus lens may further worsen the angle narrowing. The onset is usually seen between 3 to 6 months of age, particularly during the cicatricial phase, though it can present later. PFV is typically unilateral. It is frequently associated with microphthalmos and elongated ciliary processes, which further contribute to the abnormal anatomy and risk of glaucoma development. In retinopathy of prematurity, angle closure can occur as a late complication of abnormal fibrovascular proliferation. The main mechanism is contraction of retrolental fibrovascular tissue, which progressively shallows the anterior chamber angle and leads to secondary angle closure. In addition, structural factors contribute. These eyes often have a steeper cornea and an increased lens thickness to axial length ratio, both of which crowd the anterior chamber. Iris neovascularization may further compound the risk by driving synechial closure. Management begins with laser peripheral iridotomy as first-line therapy. If angle closure remains uncontrolled, more invasive interventions such as lens extraction, trabeculectomy, or tube shunt surgery may be required. Drug-induced secondary angle closure is most commonly associated with topiramate, a medication widely used for epilepsy, depression, migraine prevention, and idiopathic intracranial hypertension. The underlying mechanism is uveal effusion, which pushes the iris lens diaphragm forward, leading to a sudden shallowing of the anterior chamber and angle closure. Clinically, patients may present with sudden bilateral vision loss, an acute myopic shift, ocular pain, and headache. On examination, we can see a shallow anterior chamber, forward displacement of the lens iris diaphragm, microcystic corneal edema, and intraocular pressure that can range from 40 to 70 millimeters of mercury. Although topiramate is the most recognized culprit, other drugs can trigger this as well, including acetazolamide, methoxylamide, bupropion, Bactrim, and even MDMA. A key diagnostic clue in drug-induced angle closure is that it is often bilateral, unlike most other forms of secondary angle closure. The very first step in management is to stop the causative drug. Medical therapy includes the use of aqueous suppressants to lower intraocular pressure, cycloplegia to deepen the anterior chamber, and systemic corticosteroids, which can help reduce inflammation and speed recovery. The course is usually favorable. Angle closure often resolves within 24 to 48 hours, while the associated myopic shift resolves within 1 to 2 weeks. Finally, it is important to note that peripheral iridotomy is not indicated in this setting, since the mechanism is not pupillary block, but rather uveal effusion with forward displacement of the iris lens diaphragm. This slide shows ultrasound imaging of topiramate-induced angle closure. On the left, the B-scan demonstrates a very shallow anterior chamber marked by the asterisk, with choroidal effusion clearly visible along the posterior pole, indicated by the arrows. On the right, we see an ultrasound biomicroscopy view. Here, the anterior chamber is extremely shallow, with the angle closed, again marked by the asterisk. The posterior choroidal effusion is also well seen, highlighted by the arrow. These findings illustrate the classic mechanism of drug-induced secondary angle closure: choroidal effusion leading to forward displacement of the iris lens diaphragm and not pupillary block. Now we move into combined mechanisms. First one, we will talk about ocular inflammation, which can lead to secondary angle closure through several mechanisms. When the blood-aqueous barrier breaks down, fibrin and proteins accumulate in the anterior chamber. This promotes the formation of both posterior synechia and peripheral anterior synechia. The sequelae include a secluded pupil, iris bombée, and ultimately secondary angle closure. Additionally, inflammatory debris, KPs, and peripheral iris edema can also contribute to PAS formation. A key distinction here is that in inflammatory causes, PAS tend to form inferiorly, whereas in primary angle closure, they more often form superiorly. Here we can see two classic examples of inflammatory glaucoma. The top image shows a patient with ankylosing spondylitis who developed a fibrinous anterior chamber reaction. Notice how this reaction has led to the formation of posterior synechia, which can distort the pupil and set the stage for secondary angle closure. The lower image highlights another complication, a secluded pupil with iris bombée. This occurred in a patient with long-standing uveitis, where synechia and pupillary block ultimately produced secondary angle closure. These pictures reinforce how chronic inflammation can directly remodel the iris-lens interface and cause glaucoma. This photograph demonstrates PAS in the setting of uveitis. Notice that the synechia here are located inferiorly in the anterior chamber angle, which is a common distribution in inflammatory glaucoma. Unlike the smooth, uniform adhesions we may see in primary angle closure, these PAS are irregular in both height and shape, reflecting their inflammatory origin. This irregularity is an important clue. When you see non-uniform synechia, especially inferiorly, think about chronic uveitis rather than a purely primary angle closure process. Inflammation can also cause angle closure through mechanisms beyond synechia. One pathway is the development of uveal effusion and anterior rotation of the ciliary body. In severe posterior uveitis, inflammation can lead to exudative retinal detachment or choroidal effusions, both of which push the lens iris diaphragm forward, resulting in angle closure. When it comes to treatment, the priority is to control the underlying uveitis. This is best achieved with a combination of aqueous suppressants and corticosteroids, which form the mainstay of therapy. Prostaglandin analogs can sometimes be used, but they must be approached with caution since they carry the risk of exacerbating intraocular inflammation. Now let's talk about a shallow or flat anterior chamber, which carries the risk of peripheral anterior synechia formation. When this occurs after cataract surgery or filtering surgery, one of the first concerns should be a wound leak, which can be quickly assessed with a Seidel test. The initial management strategy focuses on reforming the chamber and preventing complications. A pressure patch or a bandage contact lens can be used to help seal the wound and allow fluid reaccumulation. If the anterior chamber does not reform with conservative measures, then surgical repair is required. This step is critical because failure to restore the chamber can lead to angle closure and secondary complications such as ocular hypotony. When managing a shallow or flat anterior chamber, there is an ongoing debate between conservative care and early surgical repair. Some clinicians advocate for immediate wound repair, particularly within the first 24 hours after cataract surgery. Others prefer to observe closely and use corticosteroid therapy to control inflammation and reduce the risk of edema or synechia while monitoring for spontaneous resolution. The key risks are serious and dictate when early intervention is necessary. If there is iridocorneal contact or if the intraocular lens comes into contact with the cornea, urgent reformation of the chamber is required to prevent endothelial damage. Likewise, if there is corneal edema, significant inflammation, or high risk of posterior synechia, early repair should not be delayed. Ultimately, the management approach must balance the risks of waiting with the risks of surgery. Here, we return to the overview of causes of secondary angle closure. This is the algorithm we have been following throughout this section, beginning with whether the mechanism involves a pupillary block or occurs without pupillary block, and then dividing further into pushing, pulling, or combined mechanisms. I won't go through this diagram in detail again, but it's helpful to keep in mind as a roadmap while reviewing each condition. That concludes our review of secondary angle closure mechanisms. I know this was a dense topic, but you've worked through some very detailed and challenging material. Great job staying engaged and following the algorithm step by step. If you'd like to test your understanding, practice questions will be available at the end of this lecture. Thank you again for your attention and dedication. You're doing excellent work.